All right, I think we should start. Good afternoon, everybody, from Cape Town. We are welcoming Professor Andre van Niekerk this afternoon, private pediatrician and pulmonologist. And we've asked him to talk about primary immune deficiencies. And this is a topic that always gives us a lot of headache. So Andre is going to break it down for us in simple terms, how to tackle these difficult patients. I'm going to ask everybody to mute your microphones, that we don't have interference. And then I'm going to hand it over to Professor Andre van Niekerk. Okay, I'm just asking Andre to share his screen. Here we go.
Vera, thank you. I'm humbled by the invitation to talk about primary immune deficiencies in children. And, you know, I must first of all say that I don't have any conflict of interest related to the topic. But at the same time, I need to disclose that I'm not an immunologist. I'm a pediatric pulmonologist. And I got a bit carried away about children in the pediatric pulmonology practice who present with recurrent infections. And that's where the interest in primary immune deficiency started. First of all, this is a huge topic. And to try and unpack it in such a short time is impossible. So I really tried to select pieces of wisdom that I hope will benefit, especially our registrars. After an introduction, I'm going to try and share some clinical clues that may direct us to think in terms of PID, and then say something about the classification of PID before just basically touch on basic investigations that we should be considering. And then I'm going to conclude. So from an introductory point of view, I think the first pearl of wisdom that we should not forget is that secondary immune deficit occurs more commonly. And therefore, we should always think about the possibility of a secondary immune deficit. In South Africa, in our context, there's no sense looking into PID if you haven't done an HIV test, for example. But we should not forget about the other reasons. And we're often caught out by things like a nephrotic syndrome patient that presents first with recurrent infections, protein-losing states. Of course, it's obvious that children on immune suppressive treatment will be more infection prone, but we must also not forget about common drugs that we use, like the anti-epileptic drugs, that can lead to an immune deficit. So think secondary before you think PID. And then when we start thinking about PID, we must remember that PID is a problem where we've got poor or absent function of a component of the immune system, and that it is related to a genetic origin. So there's a genetic origin to PID. And then immunology touches every corner of medicine. And therefore, these patients present with heterogeneity in terms of their phenotypes. It can really affect almost any organ system. And I think sometimes we are so impressed with the possibility of it affecting so many organ systems that we forget the simple things. But a child, for example, and I'll show you, with recurrent otitis media, without any other manifestations, could be a PID patient. The bottom line about PID is that the patients suffer from an increased infection burden. And I want to make the point that they do not need to present initially that way. There are PID patients who present differently without an increased burden of infection, but usually they come to our attention because of the infection burden. And this is the point, that when your immune system misbehaves, it can do so in different manners. It could allow infection when it should not be allowing infection. But allergy, for example, is a form of immune misbehavior. Autoimmunity is a well-known form of immune misbehavior. and the same with certain malignancies. So these things go hand in hand, and therefore internationally there's a call that we should actually stop referring to pure PID, but rather talk in the broader sense about the inborn areas of immunity. And it's very possible that your child that you diagnose with OTP or ITP, with thrombocytopenia, could actually be a PID patient presenting with an autoimmune manifestation. So we should think broader than just PID when we're dealing with these patients. PID as a rare disease, you know, this is the big problem. We've painted PID into the corner of rare diseases, and therefore we don't think PID, and we know that this is no longer true. All over the world, PID is no longer considered as a group of rare diseases. There are growing numbers, some data, community-based data from the United States indicate a prevalence of about 1 in 1,200 children. Some of the more common PIDs, like a selective IgA deficiency, 1 in 300 to 1 in 500 children. And you will agree, you know, in South Africa, we are very well equipped to deal with cystic fibrosis, for example. And if you just look at these prevalence figures, then PID is almost 3 times more common than cystic fibrosis in a Caucasian population. At the moment, we are aware of about 350, more than 350. I think we're closer to 400 now, known PID diseases that are genetically linked. And the other misconception in our practice is that we sort of expect these patients to present as severely ill inpatients. Now, there's a very interesting survey here that was done by the Immune Deficiency Foundation, and they surveyed a group of almost 3,000 known PID patients, patients that already received a diagnosis of PID. How many times were they admitted to a hospital? And just look at these figures. You know, almost 30% of these patients never admitted to a hospital. And there are those patients who are recurrently and frequently admitted to hospital, but more than 30% not hospitalized before their diagnosis of PID was made. Are these patients children, or could they be adults, or could they be teenagers? Once again, I think we believe that they should be babies and they should be young children because it's got a genetic origin. And same study, once again, showing us that this is not true, with more than 40% of patients only diagnosed in adulthood. And therefore, we are seeing children presenting at 12 years of age and 14 years of age and new diagnosis of PID. Who do they consult? Are they diagnosed by the intensivists? Are they diagnosed by the pulmonologists? And if we look at the type of infection, the manifestations, then it's the common infections that these patients present with. So who will be seeing our PID patients? If you just look at the percentage of patients who present with sinusitis, bronchitis, pneumonia, ear infections, etc., then they should be with a GP and they should be with a general pediatrician. And the pediatric pulmonologist will usually be the people, ear, nose, and throat specialists in private sector, who will be consulting these patients, often not knowing that they're actually dealing with a PID patient. And how well are we equipped to deal with PID patients? And I wanted to show this because it's from America. It's a survey by the American Medical Association, where they commissioned a study amongst pediatric pulmonologists to see how much pediatric pulmonologists know about PID, and 485 practices took part in the survey. Half of those said that they've dealt with a PID patient, at least one of them in the past. And if you look at how well they felt they were equipped to deal with PID patients, the pulmonologists, then you can see there that almost 80% felt that they did not receive adequate training and that they were not really comfortable. And that was clear from how they treated the PID patients. The same study looked at the use of intravenous immunoglobulin administration, comparing the diagnosis, specific PID diagnosis. On the bottom there, you can see chronic granulomatous disease, common variable immune deficiency, hyper-IgA, etc., and hyper-IgM, etc. And on the red bars, you've got the decision to give immunoglobulins by by immunologists, and in the blue bars by the pulmonologists. And you can see that the pulmonologists really had it wrong all the way. They gave immunoglobulins when they shouldn't be giving immunoglobulins, and they did not give immunoglobulins when they should be giving immunoglobulins. So I think the message is clear that we are underdiagnosing and underestimating PID, and that we're also not correctly treating them, and that these patients walk around for a long time without the proper diagnosis. So when should I suspect that I could be dealing with a child with a possible PID? I think it's actually simple. There are basically three main reasons why a child would present with recurrent infections. It's first of all just a normal child. In other words, the typical crash-going child. And I think this lockdown has demonstrated this eloquently. You know, we're not seeing COVID yet in children and up in Gauteng, but we're also not seeing RSV, and we're also not seeing all the other infections that we often see this time of the year. So it could be just a normal child that's exposed. The second possibility is that we're dealing with a child with immune dysfunction. The allergic child could be more airway infection prone, for example, or we could be dealing with a child with a PID. And then thirdly, we could be dealing with a child with a non-immune chronic problem, a barrier problem, for example, like the cystic fibrosis patient or the child with a primary ciliary dyskinesia. Bottom line is we need to think along these three lines. If it's a normal child, I don't want to unnecessarily investigate that child, and I don't want to unnecessarily treat that child. If it's an immune dysfunction, I want to diagnose it effectively and treat it, and I don't want to miss one of those other diagnoses like cystic fibrosis, for example. So if we keep this in mind, then I think it makes it more practical in terms of our approach. And Eric's team, this is American background, the secondary immune said that if a mother sits in front of you with a child and she's worried about recurrent and problematic infections, then this is more or less the scenario that you're facing. 50% of those patients are usually normal children that are just more exposed to infection at the age where they are more infection prone, for example. But 30% of those children would likely be a child with an underlying allergy predisposing them to more infections. But 10%, that's one in 10 children presenting with this complaint or concern about recurrence of infections. Could be a PID, and another 10%, one of those other conditions like cystic fibrosis, for example. This is a handy piece of information. It comes from the Jeffrey Modell Foundation. It's called the 10 warning signs to a possible underlying PID. And I think one must quickly just look at this. So children presenting in one of these 10 ways should be considered as a possible PID patient. And just look at that: recurrent otitis media more than 4 in a year, or severe sinusitis more than twice a year. Antibiotics, those children who take antibiotics 60 days of a year should be considered as a PID patient. Pneumonia more than 2 episodes, growth faltering with recurrence of infection, patients with deep skin infection, organ abscesses, children presenting with thrush, fungal skin infections, that's problematic. The need for intravenous antibiotics to clear infections. They don't respond to oral treatment. More than 2 deep-seated infections, like, for example, meningitis twice, or, for example, a septicemia twice, and, of course, patients with a family history of PID. So when you see these warning signs, they could be clues that you've got a PID. But Monica Esser, I think she did it well, and she coined an acronym called Spur. So whenever you're seeing a child with a concern about infections, and those infections are just more severe than expected, more persistent than expected, or infections that are more unusual or recurrent than expected, in those patients you should consider the possibility of a PID. And then my part-time boss, I want to show you a slide of what he added onto Spur, but before I go there, if you've got a child who presents with severe, persistent, unusual and recurrent infections and there are other features going with that hand in hand. That should really raise concern. I've already mentioned the child that's not growing well, the faltering child. Infections not only involving one organ system. If you've got gastrointestinal infections together with airway infections, that should raise concern. The child with chronic mucopurulent secretions, the ear that's just always pouring, for example. Children that are more lethargic, often absent from school, the family history I've mentioned already. The child that had the complication from the BCG vaccine that we gave, or another live vaccine that we gave. We must be concerned about children with recurrent infections and syndromic features. We see lots of children that's got, hypermobility syndrome, for example, abnormal dentition, the abundance or absence of lymphoid tissue, for example, unusual skin rashes. And then one thing that's really a good clue, if you look back into the full blood count, and there's always a lymphopenia on the full blood count, that should raise concern. For a child with a low calculated globulin, take my albumin, subtract it from the protein, and if the globulin fraction is decreased, it should raise concern. And children presenting with autoimmune disease together with infection, one should be worried about PID. And remember, the autoimmune disease that they present with in childhood is usually a cytopenia, thrombocytopenia, cytopenia, or gastrointestinal inflammatory bowel disease. And we are seeing more children with inflammatory bowel disease than I could ever have dreamed of. And as I said, the Spur acronym, severe, persistent, unusual, recurrent infections, Professor Robin Green, who's my part-time boss, he took it a step further and he added to Spur RIBS. So if you diagnose a child, for example, with allergy, but the infections don't clear, you treat him and the child returns in bad shape. So we've got severe, persistent, unusual, recurrent infections, and especially if the child returns in bad shape, then we should be considering an underlying PID. The other helpful aspect that helps us a lot in being concerned about PID is the signature that the pathogens leave. Certain pathogens, and especially if they recur or they're problematic pathogens, one should be considering the possibility of a PID. For example, if you're dealing with infections in encapsulated organisms, Giardia, etc., you can look at this list here, mycoplasma that's struggling to clear, one should be thinking the possibility of an underlying B-cell deficiency. T-cell deficiencies, you all already know about, the unusual infections with viral infections. For example, the child who presents with a cytomegalovirus pneumonia and the HIV test is negative. One should be worried about an underlying PID. But other pathogens that are not normally that problematic and they become problematic, the viruses, the fungi, consider the possibility of an underlying PID. One that we tend to also forget about, I'll say something about it in a moment, is complement, but also the phagocyte defects, those patients who present with problematic Staphylococcus aureus, for example, abscesses, etc. Think about the possibility of phagocyte defects. And if patients present, and this is the one that I said we forget about often, is problems with encapsulated organisms like Pneumococcus haemophilus, Neisseria meningitidis. Doesn't only mean that it must be an antibody problem. It could also be a complement problem. And we, for example, see children with pouring ears, chronic otitis media with mannose binding lectin deficiency. But at the end of the day, context is what remains crucial. And there are many signs that could point towards a PID, many clues that could point towards a PID, but context remains crucial. And it's just a matter of those infections that are too often, too great in number, they are too severe, the infections just last too long. They last longer than they should be lasting. They fail to resolve. The child is not perfectly well in between infections. and especially infections associated with complications. You don't expect these complications. Child's got an otitis media and ends up with a meningitis. That's what we don't expect to happen. Think PID. And I think we should also take paternal concern into account. So if a parent is worried that there's something wrong with the immune system, I'll show you that very basic screening tests are actually not expensive, and that one should consider doing it if a parent is really concerned about it. But how do we classify the PIDs? And there are more than 350, 400 of them. So we need a catalog to classify them. And it is difficult, it is complicated. The International Union of Immunology Societies, they've got an expert committee on inborn errors of immunity, and they every 2 years review the classification of the PIDs. And these are the chapters that they use to classify the PIDs under. And you can see that it's extensive. Included there, we know about our cell-mediated immune deficiencies, our humoral immune deficiencies, combined immune deficiencies, antibody deficiencies, and I go on with the list, but I want to point to it's the lower part of the list, where we've got also other conditions like autoinflammatory disorders and phenocopies of PIDs that we most likely not that familiar with. It's a big list and it is difficult. We're talking about molecules and genes, it's difficult. But I want to introduce you to this app. This app is free of charge. You can download it from the App Store. And what this app does every 2 years is they literally take this catalog and they turn it into a phenotypic approach. So you can just follow the steps on the app and it could guide you a long way around finding the PID. But for everyday use in practice, I think this article, McCusker article, I think this is a great article for registrars to read and for everybody of us, because it gives a beautiful, broad understanding of PID and it gives us a nice approach to PID. And it reminds us that we are dealing with two big categories of PID, the innate immune system deficiencies, like the phagocyte disorders and the complement disorders that I've already mentioned some of, and then the adaptive immune system abnormalities, B cell abnormalities, T cell abnormalities, and combined BT cell abnormalities. And we don't need to go through this now, but when there's a problem with B cell development and maturation, you'll have an antibody deficiency. If there's a T cell problem, it could be pure T cellular immune disorder, or you could then have a combined disorder because you need the T cells to guide the B cells. And if B cells are not guided effectively by T cells, you've got a combined immune deficiency. And this is just to show you some examples. Innate immune deficiencies complement different stages in the complement path. And you can see that patients may present with autoimmune-like manifestations and infections. We know very well down in Cape Town about complement C5 and the Neisseria infections that are recurrent. And I think in private practice, patients struggling with encapsulated organisms, the otitis medias and sinusitis, C3 mannose binding lectin, that could be a problem. Other disorders of innate immunity, the phagocyte defects. I think chronic granulomatous disease is the most famous one, really a bad disease, but there are other conditions as well that we should keep in mind. The B cell antibody mediated deficiencies, they are the most common. And if we at least learn about these ones, then we will go a very long way in practice in resolving our patients, especially those patients who present with recurrent sinopulmonary infections, especially problematic with encapsulated organisms, the Haemophilus, Pneumococcus, Moraxella. Remember that some of them may present, once again, I'll show it now, with autoimmune and allergy manifestations that overlap. But they are the more difficult T cell disorders. And then we've got the syndromes, the combined immune deficiency syndromes, like Wiskott-Aldrich, ataxia telangiectasia, DiGeorge. I think it's worth just reading these syndromes, because sometimes the penny just drops when the patient walks into your rooms. I had a beautiful example recently of my colleague, AJ, who saw a brother of the actual patient, and the actual patient, mom brought the other child with a problem. The child that actually ended up with the biggest problem was the child who just came as a visitor. And AJ noted that this child had red eyes and was stumbling around in the room. And he diagnosed ataxia, telangiectasia, and the older child without the mother even bringing that child in. So often you can spot that if you know about these syndromic disorders. But I think I just want to mention a couple where I think we fail in our general practices on a daily basis. The first one that I want to mention is selective IgA deficiency. So selective IgA deficiency is the most common. IgA deficiency is the most common immunoglobulin deficiency that we see in children. It's very common. And therefore, and it's mostly a lab diagnosis. Or if they're symptomatic, it's a milder problem. But it's mostly a lab diagnosis with seldom any clinical significance to it. But these patients may present with recurrent sinopulmonary infections. They may have an associated allergic or autoimmune disease. And this is quite frequent that they present also with allergies, and quite frequently that they, as young children, present with autoimmune manifestations like inflammatory bowel disease or celiac disease. And therefore, if this mom says that her child is complaining of chronic abdominal pain, we shouldn't just be ignoring that concern. The diagnostic criteria, I think, is important. They've got a really low IgA. IgA is often just decreased, but and that's what we refer to as IgA light deficiency. But for an IgA deficiency, you really want to see actually a really low IgA value. Usually the IgG and the IgM levels are normal, and one must exclude another form of PID, because IgA low is often part also of one of the other PIDs. And just a reminder that we can't diagnose them before 4 years of age, because IgE levels are low, physiologically low in young children, and their levels increase as they age. So one's not supposed to diagnose an IgA deficiency really before the age of 4 years. The other one that we commonly deal with is transient hypogammaglobulinemia of infancy. And this is just a prolonged physiologic nodder of a lower immunoglobulin level, and we especially see it in premature born babies. Boys and girls are equally effective. If they're symptomatic, they may once again suffer from recurrent sinopulmonary infections, and they may also once again suffer from associated allergy. And this is the problem. We diagnose the allergy, we treat the allergy, but the child remains symptomatic, and this is what we mean with return in bad shape. Go further and go and look for an underlying associated problem. They've got a decreased IgG level. IgA and IgM may also be decreased. And this is important. They've got normal vaccine responses. So if you measure the vaccine antibodies, they do respond to vaccines. And that's what sets them apart. And once again, immune deficiencies wax and wane, they change over time. One must always wonder, is this part of another PID? But it's quite common. We see these children, and if they're really symptomatic, they may need temporary immunoglobulin replacement. Another one where we often falter is common variable immune deficiency, CVID. And CVID is the disease of older children. If a child presents to you with an immune deficit, at the age of 4, and he's already got bronchiectasis, it's unlikely CVID. CVID starts off in childhood often. 25% of them in childhood, they're usually diagnosed in primary school years or early high school years, and boys and girls equally effective. And the presentation is once again very much like the transient hypogammaglobulinemia of infancy children with recurrent sinopulmonary infections. They've also got associated allergy, but it goes further than that. They may present with gastrointestinal complications, once again, both infections and other complications like autoimmune manifestations, and they are at risk of malignancy like lymphoma or gastric carcinoma. The diagnosis, very specific criteria that we must fulfill. IgG must be low. There must also be either a low IgA or IgM, and there must be B cells present. And this is different to transient hypergammaglobulinemia. They've got poor or absent vaccine responses. Or if they do respond to the vaccines, they lose it again. It wanes again. The other one that we often struggle with a bit, and that's quite common, is antigen-specific antibody deficiency. And these are those patients who are unable to produce antibodies specifically against the polysaccharide antigens. In other words, they don't produce pneumococcal antibodies, or they don't produce Haemophilus antibodies. But once again, remember that this is pretty true for all young children. So you can't really diagnose it in young children. And we sort of expect the child under 2 to fail production of good polysaccharide antibodies. So it's the older child where you will be considering this diagnosis. And the criteria, there should be an isolated polysaccharide antigen non-responsiveness. They should be responding to the protein vaccines, like tetanus, for example, encapsulated organisms. They've got normal immunoglobulin levels, their subclasses are normal, and they just fail to produce polysaccharide antigens. And they struggle really with especially recurrent upper airway infections. Once again, the associated allergies. So allergy may not be the only reason why this patient is symptomatic. And then lastly, we don't have time to go through all 354 of these diagnoses, and I really don't know them myself, but we need to say something about SCID. And the reason why we need to say something about SCID is it's more common than we think. We've had about 6 cases in the last year. They present as babies usually, under 1 year of age usually. The leaky skids, they may present up to 5 years of age, but they're symptomatic from a young age. They've got a high burden of pathology with chronic diarrhea, they fail to thrive, they've got skin rashes, the recurrent and often severe infections. And the diagnosis is really one of see those absent lymphocytes. If you look at that full blood count and those lymphocytes are absent, you should really be worried about these patients. They've got a lymphopenia, T-cell lymphopenia, and they may unfortunately have normal B lymphocytes or even increased B lymphocytes. So you can't just look at the low lymphocyte count if you suspect it. They don't produce antibodies, and therefore they don't also produce vaccine antibodies. The important thing about these children is that it's a fatal condition, and one must early diagnose them, because you can transplant them. They recover fully on a bone marrow transplant. They've got a normal life outlook on a bone marrow transplant, and you don't need to offer a perfect match to them. You can do a haploid transplant on them as long as you do it early, preferably before their first infection. So if there's a family history, one must think of it, and you must put them onto preventative treatment as soon as possible. They must really not get their BCG and their polio drop, and one should give them immunoglobulins early and really nurture them, because they can do well if we pick them up early. In terms of investigating, we're thinking that you might be dealing with a PID patient. What should we do next? Well, the first thing that we should do is, and I've already said it, exclude the HIV. Make sure that you're not dealing with a secondary immune deficiency. Check the urine, look for protein loss in the urine, and do at least an HIV test. And then you proceed and you do first line PID investigations. We classify it as first, second, and fourth line up to fourth line investigations. I think for all of us in practice, we should at least be doing first line investigations. And what do you need? You need a normal full blood count, and even better, serial full blood counts. If you can print a cumulative report and look at previous full blood counts, the neutrophils are always low, be worried. If the lymphocytes are always low, be worried about this patient. Just do calculated globulin. What's the albumin and what's the protein? If the globulin fraction is low, worry about the possibility of a PID. And then at least do the basic immunoglobulins, an IgG, IgM, an A, and an E. And remember, E is more an indication of PID than allergy, really. It's not, we're talking of total IgE. And a patient with a very high total IgE, one should be worried about the possibility of a PID and not only get stuck with allergy. And then the other first-line investigation is to just measure the specific antibodies to tetanus and pneumococcus. If this child has been recently vaccinated or is fully vaccinated, you do expect a good tetanus antibody level. And if it is especially an older child, older than 2 years or so, you do expect a good level of pneumococcal antibodies. We, in other words, measure the total, we count the antibodies, and then we measure quality of antibodies just by looking at the vaccine-specific antibodies. So I think one should do this as first-line investigation, and that could already give you a good idea that you're dealing with an underlying PID or not. So at least offer this. This is cheap and it's freely available throughout South Africa. We then go further and we do second-line investigations, and this is where you need to start thinking and consulting your app. This should be now more appropriate. If the lymphocytes are always low, let's do the lymphocyte subsets. Which lymphocytes are the missing ones? If we may decide to do IgG subclasses, it's not a first-line investigation. IgG subclasses is expensive to do, but let's say, for example, this patient has no pneumococcal antibodies and doesn't respond to a pneumococcal revaccination. One could consider IgG2 subclass deficiency, for example. We may decide to do complement or neutrophil oxidative burst test if we're expecting a phagocyte problem, for example. And we could go further. I'm not going to go into the detail, but you can see the more we get involved in this patient, we more start doing functional tests as well, functional assays, and there are really fancy tests around and tests that can be very confusing and difficult to interpret, and we really need to be guided when we get there. But one thing I want to say about fourth-line investigations, and that's genetic testing, next generation sequencing. We think we live in the third world and we can't do these things, but it's becoming cheaper and cheaper. It's becoming more and more available, and genetic testing is now often the way forward in diagnosing a patient effectively. And I just want to use this, I'm basically done, but I just want to use this as an example. This is what we use, our guide on when should we offer a patient immunoglobulin replacement therapy, when should we consider giving them immunoglobulins. This is a very easy way. You don't need a specific diagnosis. By just looking at these 3 lab investigations, we counted IgG, we looked at the quality of IgG, was there a good vaccine response after we revaccinated, and we count B cells, B lymphocytes. And if those are all absent, the patient obviously needs immunoglobulin replacement therapy, rather urgent. If they decreased, even with B cells present, we will still need immunoglobulin replacement if this patient is symptomatic. But let's say, for example, I've got a patient who's got normal IgG, but the quality of the IgG is lacking. He's got B cells, but he's symptomatic. Then we need to speak to someone and consider offering this patient immunoglobulin replacement therapy. And if this is a patient with low IgG, the quality of the IgG is normal, the B cells are normal, like with the transient hypogammaglobulinemia that I mentioned, but this patient is really symptomatic, we may consider giving this patient immunoglobulin replacement for a short period of time, for example. So it could be very simple on the other hand. I want to conclude and conclude by reminding you that PID means increased susceptibility to infection, and we know that. But it's not only an increased susceptibility towards infections. It's also about associated allergy. It's about associated immunity and autoimmunity and malignancy. And they may present with the allergy first or as the major manifestation, or they may present with autoimmunity and suffer from an underlying PID. These are immune system dysfunctions that's got a genetic origin, and therefore genetic sequencing could be very helpful in most of these patients, many of these patients. We should always exclude a secondary immune deficit first, and remember that it's not about babies only. Well, with the kids, it should be about babies, but it's also about older children, and it's also about adults. These patients often present with recurrence of common infections. So that mother that's worried about the 6th otitis media, she deserves at least a first-line PID investigation. And I hope with this talk, I could motivate you to start thinking PID. It's not that rare. If we diagnose these patients early and we treat them effectively, then we do improve their quality of life significantly, but we also prevent end organ damage like bronchiectasis, for example, and we also improve mortality in these patients. It's time for back to school. And we are in COVID-19. What do I say to parents? They're driving us at this stage. We're getting many calls a day. What do I say to them in the light of the COVID pandemic? This is a joint statement on SARS-CoV-2 during the pandemic, and it was a joint statement by a whole host of international. The South Americans are there, the Africans are there, the Europeans are there. On the 28th of June, at this stage, we do not know a lot with COVID and our PID patients about it, but there are certain PID patients that should remain in isolation and should not return to school. Those with comorbid lung and heart complications, disease, the post-transplant solid organ, as well as the stem cell transplant patients, or those patients we don't have them in South Africa really with gene therapy, and they shouldn't go back to school. Those on treatment for a comorbid malignancy should not go back to school, and those on immunosuppressive treatment, like with the autoimmune diseases, should most likely stay in isolation. I think what is important is to remember that, like with any other virus, some of our combined immune deficiency patients may fail to clear the infection. We see that in our patients with CID, that they, for example, pick up an RSV virus and they fail to clear the RSV virus. And those patients with humoral immune deficiencies, like our Bruton A gamma globulinemias, the patients on immunoglobulin replacement therapy, we must remember that the immunoglobulins currently available do not contain antibodies to COVID, SARS-CoV-2. In other words, the infusions or subcutaneous immunoglobulin therapy will not protect them against COVID disease. And I think there's a big problem here also, that we must remember that we cannot use things like, for example, an immunoglobulin muscle intramuscular injection once a month to protect a child that we do not want to fall ill with COVID disease. Therefore, in children with a PID and in the current pandemic, it should be an individualized risk-benefit-based approach where we decide for each child whether it's better to stay at home or not. And thanks a lot once again for the invite. And I want to thank Prof. Green, who's really a big motivation, Prof. Monica Esso, who's really taught a lot and who's a good motivator. Thanks a lot.
Thank you, Andre. That was a very comprehensive overview on PIDs, and it answered quite a lot of my questions. If you guys have got questions, please type it in the chat box. We can see if there's any questions that we can pose to Andre. I think I'm going to kick off with a situation that we often have in ICU, where we have this frequent flyers coming in. I'm thinking of our trisomy 21 babies with recurrent pneumonias, often a heart condition flooding the lungs, some aspiration potential. So they're coming in regularly. When do we investigate them?
Beira, first of all, if it's a patient, you've mentioned the Down syndrome with syndromic features, I think they must be investigated. You know, any patient with syndromic features and with recurrence of infections or problematic infections should be investigated. And then I think any child where the patient is admitted to the ICU and suffers from a life-threatening infection, I think it's valid to, in that patient, at least do a basic screen. You won't believe how many of them are we actually diagnosing after an admission to the ICU. Their first presentation was admission to the ICU. I had a child recently who was admitted to ICU with a very complicated pneumonia. It was a pneumococcal pneumonia at the age of 9 years, and he turned out to be a CVID. When we did his investigations, he suffered from common variable immune deficiency. And remember what I just said, common variable immune deficiency usually present during school years. And this was a 9-year-old. So it's the age, and he had that life-threatening infection. So I think any life-threatening infection, one should at least do the basics to screen that patient.
And then in the timing of this, I'm seeing a question coming through. If you have the child now with acute infection in your ICU, can you do it then, or when is the best timing to do your screening tests?
Certain things you cannot do at that stage, and certain tests can be very helpful. Let's say, for example, you've got a child with an acute infection and you do his immunoglobulins and they are low. They shouldn't be low. Then you should really be worried about the child. But they could also be falsely raised because of the acute infection. So if they're normal, one may decide to not yet forget about the PID and rather retest that child at a later time, reinvestigate at a later time. Things, for example, like IgG subclasses, they are totally unreliable during acute infection. And therefore, one should always investigate those patients when they're well. If you think there's an IgG subclass deficiency, you can't do it in a sick child, for example. Other tests, like, for example, your lymphocyte subsets, they are affected during acute illness. Now, let's say, for example, we've got a child that comes in, a baby with a severe infection, and we do the lymphocyte subsets and his lymphocytes are absent. That's still a SCID. And, or the, you know, he doesn't have T cells. That's still a SCID. And therefore, I think one must look at the situation, and you should consider the sensitivity and the specificity of the test that you're asking for during the acute situation. And there are nice guidelines on that. So we shouldn't say he's sick, we're not going to test him now.
So is that where your app can help us?
The app will add to that. Or you can make a call. So there are clever immunopathologists around, and they know.
Okay, the next question is on immunization.
Yeah.
Is it safe to fully immunize your PID children?
Well, one must always ask yourself, what do I want to achieve with this vaccine? Will this vaccine offer benefit, or will this vaccine potentially offer harm? So if it's a child with a T cell abnormality, live vaccines will or potentially harm that child. So I do not want to give a SCID BCG, and I do not want to give a SCID patient polio drops or a measles vaccine. So if it's a child with a T cell abnormality, then go and read about it first, and definitely don't give live vaccines before you've double checked on using a live vaccine. If it's a child with a humoral immune deficiency, like, for example, the CVID patient, he's got some immunoglobulin production, and you know, some of the vaccines will be beneficial in those patients. And you can even give them then live vaccines because they've got normal T cells. So if it will benefit or only half benefit the child, you will still vaccinate that child. For example, a child that's receiving immunoglobulin replacement therapy, he's already taking immunoglobulins. Vaccines are not then really beneficial because he's receiving antibodies from the donors that he's receiving. But we must also think of what's in that donation that the child is receiving, the immunoglobulin preparation. It doesn't have, for example, the seasonal influenza in there. and we will still give that child the influenza vaccine. But in the ALSA handbook, the Allergy Society handbook that's available, and on the web all over, there are very nice and easy guidelines on when to use vaccines and on not when to use it. If you're not sure, just don't give a live vaccine. Go and read first and then decide on giving it or not.
Thank you, Andre. I see Mignon has posted there that the renal transplants, they send back to school. But I think that's probably in the setting where they are stable and well controlled. I don't know if Mignon wants to come in and add something on that.
Hi there, Andre. Thank you for a lovely presentation. I really enjoyed it. It's really hard because we were just saying at least half of Red Cross are immunosuppressed in one way or another. So yeah. I think the answer is probably to say, no, don't go back to school, but then sit back and say, but can you go back to school? And so we've said any child who's stable, who has not had a transplant in the last 3 months, we haven't been transplanting all year. And if this virus is going to be with us for a long, long time, some people are predicting a year or two, then maybe we need to kind of look at that. So it really is balancing the pros and the cons. So I think if anybody, what we've been saying to parents, if you are worried at all, speak to your pediatrician, your GP, your clinic doctor, whoever is your primary carer, and look at the pros and cons. So, and we've had a lot of transplant parents who've said, please, can we send them back to school? We really want them to go back to school. So I think that's been our kind of take, but we do realize that things are changing all the time.
Yeah, Mignon, I agree with you 100%, and that's why that last little box there that said it must be individualized. When the PID people say don't send the PID back, it's when we say that we've got a PID plus a transplant.
Yeah.
It's not only a transplant patient; it's always also a PID patient with a transplant.
Yeah.
But it must be individualized. I agree on that.
Thank you, Andre and Mignon. I see we don't have any further questions in our chat box. A huge thank you to you, Andre. We had over 200 registrars coming in to listen to us. We are recording this and we will send you guys the links out, and there's some very useful that Andre quoted that we can refer to. Thank you, Andre. I'm now going to hand over to Mignon McCullough to talk to us a bit about going back to school. This has been an ongoing issue, and those of you that's seen the news, there's quite a few schools, especially in the Eastern Cape, that's now closing up again. And just to talk to us about a little bit putting it into perspective and balancing everything. Thank you, Mignon. Over to you.
Thank you very much. So I'm going to start off with a disclaimer to say I don't know all the answers, and I've put a question mark, should you return to school? And I really want to pay tribute to the rest of the SAPA exec for putting together a very nice SAPA document that we have circulated, and that looks at all the various options. And so if you're a parent who can keep your child at school, you can guarantee them education, psychological support, safety, nutrition, and you feel strongly that this is what you want to do, we would respect your wishes. But for many children, this is not the case. And we are continuously looking at what's happening, and things change not just on a daily basis, but I sometimes feel that what you decide in the morning is not quite the same as what you decide at lunchtime, and then again at dinner time. And so one of the papers that's just come out, and I really want to thank Beira for showing it to me, is by Russell Varner and group. And Russell Varner is the Royal College of Pediatrics and Child Health Chair, so equivalent to my position. And he's just published in the Lancet a rapid systematic review on school closure and management practices during coronavirus outbreaks. And so I just want to share a little bit about this. And they've looked extensively at other viral outbreaks. So not COVID specifically, but also the SARS outbreaks, influenza outbreaks, and some of those viruses, they found that schools have not had a substantial role in transmission. And it's really worth reading that paper. As I said, it's the Lancet, May 2020. And they've compared China, Hong Kong, and Singapore, and found that not only, as we've thought there are low transmissions amongst the children, but also low acquisition of the SARS virus. So not the SARS-CoV-2, but the SARS virus in the first place. What they also suggest is that if we close schools, we then are sending those kids out into their households and into their community. And in many respects, we then increase their contacts between the rest of their families, and this may include older relatives as well as the rest of their community. And a lot of the kids really don't sit at home, but they're mixing around in their community, in the shopping centers, in public spaces, not just outside, but also in inside public spaces. And you then increase the social context between children to children, but also children and adults. And so this paper refers to it as non-school gatherings. Interesting, they say that grandparents provide 40% of childcare in the UK. I don't know the exact numbers in South Africa, but I would say it's probably at least that. And so as our level 3 is being lifted and as parents and carers go back to work, a lot of these kids are either left with the grandparents or they are left in an unsafe environment to kind of fend for themselves psychologically, educationally, but also importantly, nutritionally. And so what Russell Varner says is they've learned from other countries. They've looked at China versus Taiwan, and they've looked at closures versus non-closures of schools, and they found that often there really isn't much of a difference in what's going on there. And so if you hear that a school has got 25 students that are positive, it may just be a reflection of what's actually going on within the community itself rather than within the school itself. And so what they're advising in this paper is look at other school distancing methods. So instead of closing an entire school when you've got a large number of students or teachers, rather think about closing specific classes. Think about alternate day classes, and I know that a lot of schools actually have some students going in Monday, Wednesday, Friday, and then other students going Tuesday, Thursday. They then swap around the next week. Having different break times for different classes. So just being innovative and just thinking about other school distancing methods. Of course, you must have the basics, and so hand hygiene, very important, and we know in South Africa there are lots of schools that don't have running water. That's a basic requirement. I've seen some very innovative way where people have had buckets with taps in them, and so they don't have running water, but they have an area where you can wash your hands with soap and water. Also alcohol sanitizer for the hands. Face masks, I think, are absolutely essential, and we've had the discussion whether you can have a face mask or whether you can have a face shield, but the evidence seems to be that you must have a face mask at the very least. If you want to have a face mask and a shield, then that's an optional extra. And then the social distancing, as I've mentioned before. Again, difficult in some schools where you may have 30, 40, 50 kids in one class. And so, as I've said, from this paper, they've suggested thinking differently. Golden rule, don't go to school if you are sick. And I think that's really, really important. And then this that I hadn't really heard about, and this paper addresses the fact that if you have a community where you have tight suppression of movement for a very long time, you will then get behavioral fatigue of the community. And I must say, I've seen that around where I work and where I live. In my community where I live, people have stopped wearing masks when they walk around. I think people just feel South Africa's locked down really early, which was great. But it's now been more than 90 days and people are feeling this behavioral fatigue. And unless somebody in your family dies of COVID or has COVID, or you're a healthcare worker, I think people have got this behavioral fatigue of the community condition. So the WHO has said countries must strike a fine balance between protecting health, preventing economic and social disruption, as well as respecting human rights. And for us, we feel that is also respecting the human rights of children and their carers. And we've seen a lot of increased violence as the sector is opening up again. And we know that gender-based violence, violence against women, but also specifically against children who may be inadvertently run over by cars, get themselves into mischief as they fall out of trees, fall off walls. But in certain areas where there's a lot of gang warfare, we've seen kids being not just shot in crossfire, but actually being shot at point blank range. And that's hugely disrupting for those caring for these children. So we don't have all the answers. This paper suggests that for children, it still is best to go back to school from an educational, a nutrition, a protection, a psychological, for teenagers from a mental health point of view. And in South Africa, we know that the conditions of schools are all not the same. And so that is something that as pediatricians, we are very acutely aware of. We also need to keep learning from other countries. And so a paper like this with a systematic review, I think is really interesting reading. I don't know that it has all the answers, but I thought I just wanted to share this paper with you quickly because I think it does bring up a lot of interesting issues to think about. And we do know that COVID-19 changes day by day, every day. And so, you know what I'd like to just call a mini journal review or a mini journal club. I'm just going to say stay safe. And thank you for everything you do for the pediatric community. Thank you for supporting your pediatric colleagues. And thank you for looking after all those children in the wonderful manner that you do. Thank you, Beira. That's me done.
Thank you, Mignon. I don't know if there's any questions for Mignon. You can just type it on the text box. I'm going to ask Andre if you would be kind enough to share his PowerPoint, because I see there's a lot of you guys that's requested that. And with his permission, then we will distribute, but we will put the video link available for everybody. Just want to end off tonight. We've had some reports of pediatricians being targeted and really because of fear in the communities, them having COVID exposure, and in the communities fearing the pediatricians' children going back to school, and they've been ostracized and targeted. This is happening, and the WHO has actually put out a statement on this. This is not unique to South Africa. It's happening all over the world. It's because of our frontline workers. So with that in mind, I would like to invite all of you, if you come across any stigmatizations against yourself or your family, please let us know. SAPA would like to engage with this and to take this further. But in the meantime, best of luck to all of you. Keep on doing the good work in the front line, and all of you wear your masks and stay safe. Thank you for joining, everybody. Good night.